of today's slide seminar is AML morphology. So it is a very important topic for postgraduate students. As such, the leukemia is a very important topic in hematology, and AML is one of the important topics in morphology. Chairperson for today's workshop is Dr. Rajiv Kumar. He is professor of pathology at Homi Baba Cancer Hospital and Research Center in Muzaffarpur. And the presenter is Dr. Nikhil Patkar. He is professor and physician scientist at Advanced Center for Treatment Research and Education in Cancer at Navi Mumbai. The students for attending today's workshop are Dr. Sheena from AIMS Nagpur, Dr. Sheetal Lakshmi from AIMS Kerala, Dr. Palak from CMC Ludhiana, Dr. Ibrahim from IDMER Kolkata, Dr. Gaurav from LHMC New Delhi, Dr. Nisha from CMC Ludhiana, Dr. Neha from Solan, Dr. Shikha Chaudhary from LLRM Meerut, Dr. Shikha Gurjar from MKSMC Ahmedabad, and Dr. Umta Naik. Myself, Dr. Sufyan Zahir, I'll be moderating the session along with Dr. Ankita Asthana, and the webinar hosts are Dr. Anita Borges and Dr. Sumit Gujral. So there are certain reminders. Please, connection interruption or low and no sound or video freezing or video lag, kindly leave the meeting and rejoin. So at times, by rejoining, you can connect normally. Then please answer the poll questions if any by typing in the chat. Please do not send requests for annotation to the presenters. And there are certain disclaimers. The online teaching course for postgraduate pathology is designed to supplement the pathology learning. It is not endorsed by MCI, IAPM, or any other governing body. The context of the talk is propriety of the presenter, and any unauthorized reproduction of the content of this talk or webinar is strictly prohibited. The presenter holds the sole responsibility regarding the content provided in his talk. The organizer of the teaching course of postgraduate pathology are not involved in the development of the content. Digitized slides are used purely for educational purpose and do not contain any patient identifier and are uploaded solely at the discretion of the presenter. Organizers of the program are not involved in scanning, uploading, or sharing of the slide. Please do not use the slides of the presenter for your academic purpose or your research purpose, because that is strictly prohibited.
Zahir, you don't have to read. Okay. You don't have to read. Go ahead.
So let's start.
You have to stop sharing now. Zahir, you have to stop sharing the screen.
Can you all see my screen?
Not yet.
Not yet.
Yeah.
Yes, sir. We can see.
Yes, now we can see your screen.
All right. So if anybody is working in the background or has noise in his background, I urge you to please mute yourself.
Yes.
Otherwise, it's all good. So good evening, everyone. We are here to talk about the morphology of acute myeloid leukemia. So may I request some of the PGs here to have interaction? I'm afraid I don't recall all of your names, but maybe if someone wants to volunteer what these cells are.
Myeloblasts.
Okay, are all of them myeloblasts? Let's start with this particular cell. So I don't know if there's a
You can do laser pointer.
Laser pointer. Okay, can you see this cell? What do you think these cells are?
Myeloblasts.
Okay, myeloblasts. What about these cells?
Myeloblasts.
Myeloblasts. So what about these cells?
These are also myeloblasts.
These are also myeloblasts. And what about these? Myeloblasts. And myeloblasts. This? So because this is an AML slide, a seminar, I suppose everybody is thinking that these are myeloblasts. Okay, so I'm afraid that it is not so obvious all the time that you can say whether these are myeloblasts or whether these are lymphoblasts or whatnot. Because if you ask me what these particular cells here are, I would just call them as progenitors. They could be hematogones most likely, or early B cells, or same for here. It is impossible to say based on this whether these are myeloblasts or lymphoblasts, but one can definitely agree that these are progenitor in nature. That means these are immature cells and most likely blasts. All right. If you see cells like this with abundant cytoplasm, red granules, or cells with all rods, you can be more confident that these are myeloblasts. So some of these seem to have red granules, and I can be more confident that these are myeloblasts. All right. So now, what do you think of this cell? Monocytoid. Okay. So would you like to describe this cell a little bit more? So I describe cells like what like how you would describe something when you are cutting an orange or cutting an egg. Describe it from outside to inside. What do you think? Let's start with the shape. What do you think?
Large size.
Okay. And how do you say whether something is large or small?
So RBC, how many WBCs can accumulate in that RBC? One RBC. Like normal size of RBC is 6 to 8 micron. So
okay. So I almost never, I don't know whose bright idea it was to compare cells with microns and so on. I certainly don't have a micrometer with me or whatever is used to estimate these cell sizes. But yes, you can compare this with a mature RBC, or you can compare this diameter with that of a normal lymphocyte. And as compared to a normal lymphocyte or an RBC, this is certainly a large cell. All right. But what else can you say about it? So the cell is large. Is that all that is required? Or what else do we say when we see large cells?
Immature chromatin.
So okay, so let's describe it from outside to inside. All right. So there are two big components that we see here. That is, one is the stuff in red, and what stuff is this in red? The nucleoli are here. All right, step out a little bit. This whole big blue structure is what? This whole blue
cytoplasm is basophilic.
Okay, not the cytoplasm, but what is this round structure here? Pink color.
Yeah.
Nucleus, right? So the nucleus is large, and do you think what is this pale blue stuff here? The cytoplasm. So when you see a cell and you look at its nucleus and cytoplasm, the metric that you can derive from this observation is
there's a high NC ratio.
The nucleocytoplasmic ratio. So would you say that this cell has abundant cytoplasm or less cytoplasm?
Moderate.
Moderate.
Yeah, I would say it has a lot of cytoplasm. I would say moderate to maybe an abundant cytoplasm. And therefore, the NC ratio for this cell is actually low because the cytoplasm is increased as opposed to, let's say, this cell, right? This cell, I can definitely say, has a high NC ratio. Would you agree with me?
Yes, sir.
Yes, sir.
All right. So as you can see that even this is a progenitor and even this is a progenitor cell. This cell is a progenitor because it still has multiple prominent nucleoli. All right. Now, what do you think is happening to this cell?
Large.
So the cell is large. It has prominent nucleoli. It does seem to have
Eccentric
abundant
nucleus.
cytoplasm. The nucleus is eccentric. And what's this?
Eccentric.
What is this?
Halo. Halo is
So there is a paranuclear off, all right? A perinuclear halo. And what's happening here?
Bend.
vacuolation can be seen. Indentation is
Okay.
there.
Okay. So there seems to be, as one of the colleagues said, that there is indentation of the nuclei, and also the same discoloration is happening here, right? Isn't it? The
Yes.
same discoloration is happening here. So you can see that
Yes.
even though they are immature cells, these cells almost never read the textbooks. All right, these cells will not be what you would see on the what you see in the textbook. There is no definite boundary between what remains to be a blast and what remains to be a promyelocyte, which is the daughter progeny of a blast, because these cells are constantly evolving from one state to another in a state of normal maturation. So you will get all kinds of hybrids or stages in between. Now, what is this cell?
Myelocyte.
So somebody said that this cell is a myelocyte. Do all of you agree that this is a myelocyte?
It can be promyelo.
And can be promyelocyte. So we're seeing two sharply contrasting opinions here. What do the rest of you think? So there seems to be a paucity of opinion here. So this cell has got abundant granules in its cytoplasm. It seems to have a small amount of cytoplasm, but much more than what you would get in a lymphoblast. So there is some amount of cytoplasm. Cytoplasm has granules. If you look at the nucleus, you can see that there is this chromatin. How do you describe this chromatin as opposed to this cell?
Opened up chromatin.
So this
Open
cell,
chromatin.
very good. This cell has opened up chromatin, and this cell has more clump chromatin. All right. So as these cells start to mature from this to this to this, you can see that the chromatin pattern becomes more darker, more close. So these cells have a more open chromatin, whereas this is more blotchy and therefore closed chromatin. Okay. And what is this? What is this?
Nucleoli.
There
So
seems to be some sort of nucleoli which are there. So this too is a blast. This blast is actually going to transition into cells like these, which are promyelocytes. Now, what do you think is happening here?
Bilobe.
So is this normal or abnormal?
Abnormal.
So you're seeing bilobe nuclei
Abnormal.
here, bilobe nuclei here. All right. And what do you think is happening here?
So cytoplasmic vacuolation and
So if you were to contrast this cell with this cell or this cell, how do you think this is different? This particular cell is different.
Size.
So one is that it really has a large size as compared to maybe a normal lymphocyte here. Okay, then.
The chromatin is more condensed.
I'm not so sure about contents. I would say that the chromatin is less blotchy. I would say that it is very fine. Would you say that this chromatin pattern is fine? Perhaps. But what about the cytoplasm? Do you think the cytoplasm has any granules? Do you think it has any peculiar
No.
qualities?
No granules.
Okay, and how do you describe the color of the cytoplasm?
basophilic.
Basophilic. And if you were to describe it simply in colors, what color would you say it is?
Purple, light purple.
I would say that there is a blue color to it, right? A pale blue color. You can even argue that, at some points this looks gray as well, like you can see here or here, right? Would you say so? With a bit of imagination, of course. But therein brings the observation that these cells are large, they have abundant cytoplasm, round nuclei, low NC ratio, cytoplasmic vacuoles, and blue-gray cytoplasm. What cells do you think these are?
Monocytoid series. It can be.
Means what? What do you mean monocytoid series? Monocytoid series is right from, it's like describing a car from BMW to Alto. What is that?
Monoblast.
Right. So they're
Monoblastic.
definitely immature and possibly even monoblastic in nature, right? So I would say that these are monoblasts. Okay. And what do you think is happening with this cell?
Nuclear.
Or even this cell, for that matter?
Indentation.
So even here, would you say that these cells are related? So they are similar in some way, all right?
Yes.
So these cells have a similar blue-gray cytoplasm. The granules in these are more prominent. But would you say that these nuclei are folded? So there is definitely some kind of nuclear grooving, indentation, and folding going on. And if you were to perhaps imagine, do you think that this looks like the surface of the human brain?
Yes, sir.
Yeah. So these are convoluted, folded cells, but they are not completely folded. They still have some round structure remnant to them. All right. And you can see here that this folding is becoming more prominent. You can see that these are round, but they are still. Okay. There's some gentleman called Veera Math who started sharing his content. I would urge you not to do that. So I don't have a presentation here. Okay, can you see the screen back again?
Yes, sir.
Okay, so these cells have convoluted nuclei, folded nuclei, and there seems to be abundant pale gray cytoplasm. You can see that these are cousins or related to these cells because if you see the nuclear quality, it's kind of similar. The nuclear chromatin is fine, I would say. No, I mean if you contrast this with the previous cells like this, this is definitely more coarse chromatin as compared to this, which is fine. If you were to imagine a little bit, you can say that this is even lace-like in nature. Fine lace-like chromatin, folded nuclei, abundant pale blue cytoplasm. What do you think these cells? So monocytoid is a very generic term. So can you be a little more specific?
Promonoblast.
So there's nothing like pro-monoblasts, but definitely pro-monocytes. So they're very good. So these are, yeah, so these are also cousins of these fellows, all right? So those are monoblasts, but these are slightly more confusing in nature. So brings us to the next topic. What is a blast? So although the books say that a blast is a progenitor cell, it really doesn't have a definition. What we saw in the previous slides, all of them are blasts or blast equivalents. They are not supposed to be there in high numbers in a normal individual. But having said that, you can get varying proliferations of blasts at varying percentages, even in reactive states, depending upon what is happening to the patient, all right? And it is important to know this. So you have blasts which can be classified as type 1 blasts, type 2 blasts, or type 3 blasts. Type 1 blasts do not have any granules. They have diffuse chromatin pattern, high NC ratio, and prominent nucleoli like you can see here. Sometimes these prominent nucleoli may not be there, and at times it is impossible to say whether there is a myeloid or lymphoid blast. Type 2 blasts are like type 1 blasts, but they show the presence of these azurophilic or these red granules as you can see here, all right? Sometimes they can have all rods as we saw here, and their NC ratio is lower. That means the cytoplasm is increased. And type 3 blasts are cells like these, where the number of azurophilic granules is increased, the NC ratio is still decreased. They do not have nuclear indentation or paranuclear off or spale staining. It's important to know that because the minute you start getting a nuclear indentation or a paranuclear off, these become promyelocytes, all right? Monoblasts, they have voluminous cytoplasm, they have dispersed chromatin, and the cytoplasmic margin is irregular. As you can see here, nothing is round. They're all like, irregular, like an egg or an omelette or a fried egg kind of an appearance. And they are MPO negative, as you can see here. But they do stain positive with a particular cytochemistry, which is called as non-specific estrus or NSE. It's still a very important stain for picking up monocytic differentiation. If you see promonocytes, it's important to know that these are blast equivalents. That means if you see them in persons in large numbers, it's abnormal. Nikhil, you're muted. Yes, I muted myself, sir, for a minute. So you can see here that these cells have got abundant cytoplasm and they have, delicate lace-like chromatin. Sometimes they have prominent nucleolus and promonocytes. They are variably basophilic and can have variable number of granules. And they resemble monoblasts. And as we said before, that they look like their cousins, except that their nuclear shape is more brain-like. I call it brain-like. All right. So this is what monocytes look like. In theory, it is easy, but in practice, it can get difficult. So there's also these cells, which are figure of 8 nuclei-like cells, and these cells are abnormal promyelocytes or blast equivalents, okay? And they are intensely MPO positive, and these are abnormal promyelocytes. There is also normal erythroid cells, such as pro-normoblasts, basophilic normoblasts, and polychromatic normoblasts. These are stages of erythroid maturation. These at times are difficult to distinguish from blasts, but there are a few tricks in the book on how to recognize erythroid precursors. Number one, they are always trying to synthesize hemoglobin, and at this stage, there is intense RNA activity going on. And whenever there is intense RNA activity in cells, it results in this abundantly blue cytoplasm, right? So if you see cells with abundantly blue cytoplasm, such as immunoblasts, when you do lymph node FNACs, or when you see plasma cells when they're trying to secrete immunoglobulin, or when they're trying to secrete hemoglobin. So these cells have intense RNA activity and blue cytoplasm. The key to recognizing erythroid cells is that they have a sharply well-defined nuclear membrane, and they always have this perfect round shape. This perfect round shape is maintained by very few cells in nature, erythroid cells being mostly amongst them. And as you see that these cells mature, the cytoplasm RNA activity starts to decrease. It starts to become now more and more RBC-like. Till here, it is almost RBC-like. There is still a faint bluish hue here because after all, there is some residual RNA left. And in reticulocytes 2, which is the last stage after which they have shed out their nuclei, you still see some amount of blue discoloration. Okay, so you have the important thing to know is that if you see an entire spectrum of maturation of trilineage hematopoiesis, you almost never diagnose acute leukemia. All right, before you diagnose a patient of having acute leukemia, it is important to look at the patient's clinical details, the patient's hematological profile before you make any diagnosis of acute leukemia. Most hematology diagnoses are made on common sense hematology and then looking at pathology. Unlike certain subsets of pathology, practices of hematopathology, nephropathology, skin pathology, and liver pathology, if I can say so, require an intense correlation with the clinical side, require you to understand what's happening with the patient before you can make these diagnoses. We see this almost every year. Someone sees a pediatric bone marrow, does not know how normal children's or infants' bone marrow looks like, and calls them acute leukemia. So it is important to be cognizant with normal morphology and recognizing the fact that these always will be accompanied by cytopenia or cytosis or some form of hematological abnormality, such as organomegaly or solid tumor deposits or something of the sort. Okay, in the bone marrow, there are also other inhabitants such as, what is this?
Megakaryocyte.
Megakaryocyte. What is this?
Blebs in the megakaryocyte.
So these are young megakaryocytes, all right? These are young megakaryocytes. These are immature megakaryocytes. And what are these?
Eosinophils.
Yes.
Yes, those are the easiest cells to recognize. Eosinophils. What is this?
Basophil.
So these are basophils. What is this? Erythroid. So these are mast cells, all right? You see mast cells in the normal bone marrow as well, and it's important to recognize these mast cells. So what are these cells now? Anybody wants to take a guess? So I've written the answer here, and these are hematobones, right? So these are the B cell precursors. Now you will not believe that all of these are normal bone marrows. If you look at infant bone marrows or bone marrows of patients with ITP or bone marrows of young children for which something else is happening or they have been given chemotherapy, these cells can proliferate in large numbers, all right? And they are very difficult to distinguish or impossible to distinguish from lymphoblasts. But the key here as how these are not ALL is that these always are accompanied with trilineage hematopoiesis. That means rest of the hematopoiesis is always happening unless the patient has been treated. And in ALL patient, it will completely wipe out the bone marrow, especially BALL will completely wipe out the bone marrow. And the definitive way to recognize them is by doing flow cytometry, as they have a very characteristic immunophenotype. So what cells are these? Intense RNA activity.
Erythroblast.
Erythroblasts. Okay. And anybody else wants to say erythroblasts? Any other person wants to vote for what she says?
Plasma cell.
Plasma cell. So which side do you guys want to take? Erythroid side or plasma cell side?
Plasma cell.
Now there are some two people looking here. Maybe two heads are better than one. Come on. So let me see what the two heads are saying. Which do they agree or not?
Sir, first one is plasma cell and second picture shows osteoblast.
Okay. So does your other counterpart agree? Would you say these are plasma cells as well?
Yes.
Okay. So you have all made a mistake, or at least some of you have made a mistake, which is a great learning lesson. That plasma cells can be very difficult at times to recognize from erythroid cells. But there are a few tricks. Number one, they have an eccentric nucleus. All right. Then second is they show the presence of perinuclear Hopf. They have intense blue cytoplasm, may or may not have vacuoles. And if you see the nucleus, what does this remind you of? What does this nucleus remind you of? Some other cell? Cartwheel वगैरह वो सब histopathology में है. इधर कोई cartwheel नहीं दिखता. मैंने कोई cartwheel life में नहीं देखा. Round nucleus, yes. But what does it remind you of? So this nucleus reminds you of a mature lymphocyte. All right. Okay. So that's the trick on how to distinguish one from the other. Okay. Now what cells are these? Osteoblast. But I'm saying they're plasma cells.
Sir, one cell is showing that Hopf bar from the nuclear.
So one cell is showing off. Okay, then.
And this one is
also showing off. Then
this is
somebody saying osteoblast on top, macrophages and whatnot. So is there consensus? So the thing is, these are osteoblasts. They almost never occur singly. They often occur in clusters, and they are adherent to each other. You know what is the secret of osteoblasts? You cannot see the cell borders from each other. Okay, very often they are fused. So one thing is that. Second thing is, do you know how myoepithelial cells look like in breast FNACs? You all know that, right? Everybody's nodding like yes. Okay, so myoepithelial cells have this very eccentric nuclei. All right, eccentric about to drop, and these osteoblasts do have this. They have very eccentric nuclei. All right, so these are osteoblasts. They are normal inhabitants of the bone marrow, and in certain conditions, especially metastasis and so on, they can be increased. Certain diseases like Paget's disease of the bone and so on, they can be increased. What is this? Any guess? They are macrophages and they have eaten something. There's black stuff in them. Okay, so this is a common occurrence in hematology. You see that they have eaten something, especially black stuff, because these patients have been repeatedly transfused. So by the time they come to you, you can see that there is a lot of hemosiderin activity in these macrophages. Okay, it's the patient. The slide is telling you a story that look, this patient has got lot of transfusions. Okay, so let's discuss some cases. 15-year-old male with leukocytosis. So let's start from top. I see Dr. Sita here. All right, so Dr. Sita, I'm going to ask you first to comment on this case. Okay, so what do you think is happening here? You see some cells. What do you think the cells are?
By nuclei with high NC ratios can cytoplasm opened up chromatin and
how high NC ratio? NC ratio to cytoplasm to barbar ke hai, right? So at least moderate NC ratio, no? If not low NC ratio, isn't it? Okay. So these are what kind of cells?
Blast.
These are blasts. Okay, let's look here what's happening. They are myeloblasts. Okay, all right, myeloblasts. He says that they are myeloblasts. Would you describe this cell? What does this look like?
Bilobed nuclei.
What means what bilobe है? मेरे को तो एक ही लोब दिख रहा है.
Buttock cells.
Buttocks. We have someone very imaginative there, and he's imagining buttocks on this side. Okay, so he's not wrong. These are buttock-shaped cells, but you can also call them more politely as figure of 8 cells. Okay, there's a figure of 8 going on. All right, and these figure of 8 cells are there. They have prominent nucleoli, but the nuclei are all folded. Would you agree?
Yes.
See, look at this cell. There's definitely folding of nuclei going on, isn't it? So what do you think these cells are? See this beautifully folded figure of 8 nuclei, right? Would you agree or not? So what do you think these cells are? Somebody saying promyelocytes. Somebody saying myeloblasts. I see somebody adding promonocytes in the chat. So what do you think these cells are?
Promyelocytes.
So they're not promyelocytes. They are abnormal promyelocytes. Okay, it is very, very important that you call them abnormal promyelocytes. You will never ever see them in a normal person. All right. Now, why should you know about this morphology? They have intense what activity? They are intensely positive for myeloperoxidase. And if you see the flow cytometry these cells are, would anybody like to say what these are? HLA-DR is
positive.
HLA-DR is negative. They are positive for CD45. They are positive for CD13, CD33. They also show some amount of CD2, and they are negative for HLA-DR and CD15. Okay, so this is a characteristic immunophenotype of these cells being HLA-DR negative and CD34 negative. Here you can say that they are even dim for CD34. Okay, but typical abnormal promyelocytes are negative for HLA-DR, negative for CD34, and in contrast to normal promyelocytes, they are negative for CD15. So what do you think is the differential diagnosis here? APML. Any other differential diagnosis? So there is no differential diagnosis. All right. Whenever you get a case like this, there is absolutely no differential diagnosis. Okay. Do you think any investigation should be done before you give the diagnosis?
Yes, sir.
What do you think should be done?
MPO.
Coagulation test.
So number one, you should do MPO. Somebody also said coagulation test. Okay, then
Bone marrow aspiration.
bone marrow aspiration.
Aspiration.
What aspiration?
So bone marrow.
Bone marrow.
Bone marrow. Okay, all right. So let me tell you that when you see files like this, only MPO should be done, and you should pick up the phone and tell your clinical colleague that you should suspect an acute promyelocytic leukemia. All of you are right in which additional investigations should be done, like your coagulation profile, because these patients will have DIC, such as molecular testing and cytogenetics, but there is a very specific abnormality. But the important thing here is to recognize this on morphology. All other investigations can take place in their own time, and you definitely do not need a bone marrow aspirate for these patients. Okay, this is an emergency diagnosis. It is like the frozen section of pathology where you have to make a diagnosis ASAP, or the patient can straight away die. They die not because they have to be given atra or arsenic. They die because they require specific coagulation support. Okay, they have abnormal coagulation parameters and they require specific blood transfusion support in the form of plasma and fibrinogen. Okay. Okay, so there is some gentleman who said that teardrop pattern is very characteristic on flow cytometry for APML. Let me tell you that flow cytometry does not require that diagnosis of APML almost never is based on flow cytometry. It's a morphological diagnosis. All right, flow cytometry is like a very weak supporting actor in this stage. Diagnosis is made by morphology, and morphology alone. Confirmatory diagnosis can be made with flow cytometry and molecular or cytogenetic testing. Okay, so why it is important to diagnose this? Because patients can die immediately unless they are given transfusion support. Okay, so they are confirmed by cytogenetics as well as molecular testing. There are 3 types of transcripts that they have: BCR1, BCR2, and BCR3 transcripts. All right, these are dependent on the break point that happens as a result of the fusion, and this break point is important because each of these has a separate monitoring assay. Not important to know for today's lecture. So diagnosis must be made on morphology. Confirmatory genetics can follow later. And today there are definitive treatments for this in the form of ATRA and combination chemotherapy, or ATRA and IV arsenic, or oral arsenic as well. Okay, so APML has a typical morphology. The call must be made on morphology. It requires urgent diagnosis as patients are at very high risk of bleeding, including intracranial bleeding, and they require preventive transfusion support to prevent bleeding complications. Importantly, it is okay to overcall this diagnosis. All right. Okay, so now who answered the first case? I think Palak answered. Now there's this lady, Dr. Neha. May I interrogate you, Dr. Neha?
Yes, sir.
Let's discuss the second case. Okay, so how many of you are there? There are, I think, 10 or 15 PGs, right?
Yes, sir.
So Neha can perhaps team with Sheena and her colleague. What do you think?
Nikhil, there are 6 pages only.
Yes,
Only 6 PGs? Okay, so maybe just Dr. Neha then. I apologize. I don't know how many others. So 45-year-old male with fatigue, petechiae, leukocytosis, and blasts in the peripheral blood. So what do you see in this very miserable low power view?
Sir, the local, it's peripheral,
Peripheral smell, okay? Peripheral smell.
increased total leukocyte count.
Very good. More than that, I cannot say anything. All I can say is that leukocyte count is probably increased. Okay.
Sure.
Now, would you like to take a description of these cells? What do you think is going on?
So these are the cells, nucleus having the round nucleus and having perinuclear hop.
Okay.
Cytoplasm containing granules.
Okay.
And the cytoplasm is less likely to be basophilic cytoplasm.
Basophilic cytoplasm. Okay. All right. So you can see that the cells have a round nuclei. Do you see any grooving or convolution like in the previous case? No, they're perfectly round, right?
Yes, perfectly round.
Do you think they have granules in the cytoplasm or not?
Yes.
Yes, sir.
There is granules in the cytoplasm. And what do you think of the quality of granules? Are they big blotchy granules or thin and fine granules? Like
Fine granules.
Fine granule, thin and fine.
Fine granules, thin and fine granules are there. And I'm not so convinced about this off business. Maybe a little bit here, but not super convincing. No, there just seems to be abundant cytoplasm and lots of granules. All right. So low NC ratio is what I would say. I think Dr. Filbos has also said the same thing. And
So there is a nucleoli also. So
would you
some of
say
the
it's a,
cells.
yeah, some of the cells, right? Like maybe this guy, there is something, and then maybe this guy, there's something.
Yes.
And what's happening here?
Or
Sir, or these are the faggots.
So there is these are. So what do you think are faggots?
So these are the bunch of the roads.
Bunch of. So faggot is old English for a bunch of sticks put
Bunch
together.
of sticks.
All right, bunch of sticks put together and wrapped together. You don't want to know the new English meaning of this, but old English meaning is definitely bunch of sticks put together.
Bunch of sticks.
All right.
Yes, sir.
So these are faggots, and you can see that they are intensely positive for MPO.
MPO positivity, yes.
Okay. And but do you think so? Do you have any differential diagnosis?
So, sir, APML, it can be.
Okay, APML. Is there any? So if you didn't get to see this, would you be confident calling it APML on this? If I were to argue and say that this is CML and these are all myelocytes, why would you refuse or agree?
Single faggot cell also, sir.
No, that faggot you never saw. Now,
Okay.
so it's a difficult diagnosis to make. All right. The key giveaway here is that MPO is intense. But if you see the thing is, if you were to argue that these are myelocytes, where is the rest of the maturation? There is no blast, there is no promyelocyte, there is no metamyelocyte, there is no band form, there is no neutrophil. What kind of disease in hematology has only myelocytes, right? It doesn't talk. So there is something not right. There is an arrest in maturation with almost every cell here, if you see, looks the same. Right? The same Golu fellow with abandoned cytoplasm. Almost all of them look the same. Okay. So now, what do you think the investigations here? So, sir, even if a single blast with faggot soils is seen in smear, diagnosis is APML with arrest in maturation. So somebody asked a very interesting question. So the thing is, never make anything based on one of anything. You can get or rod like inclusions even in plasma cell neoplasms. The entire picture of the slide is what matters. Remember, life is not an examination. You have to give a diagnosis which is to be sensible. Okay, so never make anything like, there's all sorts of nonsense you learn in MD. Like even if you see one cystocyte, it is microangiopathic hemolytic anemia. I'm sure you've heard of this nonsense. Even if you see one teardrop cell, it is myelofibrosis. For heaven's sake, no. Please pick up the phone, talk to the physician, see the patient yourself, see his hematological findings, and only then you can reach all of these conclusions. All right, one swallow does not make it split. Okay, so what investigation should you do?
bone marrow aspiration.
Bone marrow flow cytometry.
So bone marrow aspiration and flow cytometry. So let me tell you once again that bone marrow aspiration is completely useless in this disease. Please do not waste your time with bone marrow aspiration. It has no use. You are going to get the same thing in the bone marrow. Anything else you are going to see different? I don't think so. Okay. So some gentleman has said molecular studies. Okay, so I agree with it. So what molecular test should you do here? Yes, PML RARA. Okay, PML RARA by fish. Okay, so let us see the fish here. So this fish is by a dual fusion PML RARA probe. Okay, this is courtesy of our cytogenetics department. What do you see here? There is one green color, and what is this?
Pink.
There is one pinkish or reddish color. Okay, and how many signals of red are there? Two. How many signals of green are there?
3.
3 to 4.
3, maybe 4. Okay, so do you think there is any fusion happening? Do you think there is any fusion happening between PML and RARA?
Yes.
Yes. But if there is fusion happening, what happens when you get red and blue together? What color you get?
Yellow.
Yellow. So where is that yellow dirty fellow? Are you seeing it? You're not seeing it. No. So I'm not so sure there is a fusion happening. And the way to interpret is that this fish is negative. Okay. So PML rara to nahi hai. तो क्या चल रहा है भाई? Okay, so we did a PCR also for PML rara. Okay, so these are positive controls, and you can see that this is negative for BCR1 and BCR3 isoforms, and like the positive control as well. But this patient is completely negative. Okay, completely negative. So what now? What will you do now? PCR is negative, fish is negative. Would you like to agree that this is? Would you like to agree that this is APML? What test would you like to do now? Somebody has said NGS. So what test would you like to do? Once again, flow cytometry. Baba, flow cytometry is going to show you the same thing. 34 negative, HLATR negative, and then you are going to be stuck with maybe this is APL. Same doubt as you had on morphology. What do you think should be done next? Yes, yes. So there is one Dr. Vijay who has given a suggestion. Okay, he has said something called as break apart fish. Do you know what is this break apart fish? Anybody, if you want to take a guess? Dr. Sita, we were discussing this case, right? Do any of you know what's a break apart fish? Okay, so let's see what we got. So we did do a break apart. Okay? Now break apart probe is unlike that of a fish for a fusion. Wherein if you get a fusion, you get a yellow color. A break apart probe is already fused. So you will have the RARA gene with green and red loci together, and you will get yellow color in a normal person like this. If the two strands are separate, like red and green here, then you can say, oh, this RARA gene is rearranged. Okay, that means the RARA is broken apart and one signal has gone somewhere, another signal has gone somewhere. Since they are not together, you are saying that these are not fused. Okay, so there is a RARA gene rearrangement. But PML RARA is negative hai. Anybody wants to take a guess? What's happening? Batao.
Translocation.
No guess, anybody? So just some gentleman is saying that other mutations like ZDTB and something. Okay, so these are not mutations; they are fusions, but with some other partner. All right. So he's right. So there is something called as variant translocations in APL. They account for 2% or even less than 2% of cases where the fusion takes place with RARA, but sometimes the partner is not PM. Okay, so these include variant translocations like PMF, like PLZF, NPM, NUMA, STAT5B, and there are several other partners that have been described. Now, this particular translocation that is most common is by PLZF and STAT5B. In this patient, we did a PCR for PLZF RARA, and you can see that PLZF RARA is positive in this patient. Okay, so there's something that you should know that PLZF RARA is a result of translocation 1170. It is rare and it accounts for 0.8% of APLs. It has a very different morphology as compared to APL. Number one, these cells show the presence of very fine granules like we saw in our case. Once again, if there is unexpected noise, or if you're having noise on the background, I simply cannot give a talk. I will just log out and maybe you can give a talk. That's better than me. It's really it behooves you to please silence your background. I cannot do this, right? So there are fine granules, Felger-like cells. They are thin or rods, and these cell patients are CD56 positive. Okay. Now it is important to know of PLZF RARA because these patients do not respond to conventional ATRA therapy or arsenic therapy. These patients do not respond. We have seen patients where we have given results of PLZF RARA. They started on ATRA. Patient doesn't budge. You have to treat them with 3+7 only then. That means with a conventional AML-like chemotherapy, and this will go on. All right. So this is a very specific diagnosis, and it is important to recognize this diagnosis. Okay. So what are faggot cells? All rods were described by a gentleman called John Orr. Okay. Our bodies are comprised of a mass of fused granules within endoplasmic reticular system, and they are comprised of fused lysosomes. The word faggot was used in archaic English to resemble a bundle of broomsticks. Okay. So now there is a cousin of this case. This is again a 14-year-old male with body ache, fever, leukocytosis, and thrombocytopenia. Again, you can see who was the person here, Dr. Neha. So what do you see here?
Sir, increased TLC count.
Yeah, again, increased TLC count. But unlike that, what do you see here?
Sir, cytoplasmic granules and sir, prominent nuclei.
Okay. So abundant cytoplasm, very dark cytoplasmic granules, prominent nuclei. Okay. And this patient too was positive for the PLZF RARA fusion. So what is the difference between this patient and this patient?
Hypergranular.
Right. So this patient had very fine, very dark, blotchy granules, and this patient had almost no granules. So very fine granules. Both of these are known variations of PLZF RARA. Okay. So there is a morphologic classification system for APL which can be classified like this. If you have a blast-like cell, you see whether those cells have basophilic granules or dark shadag-like granules. But forget about this. If you see a blast-like cell, first look at the nuclear morphology. Is it regular? That means is it round like this, or is it irregular? That means is it convoluted? Is there hypergranularity or hypogranularity? Is there presence of OR rods or there is no presence of OR rods? And based on that, you can classify these cells. So if you can see here, these are all morphologic variations of acute promyelocytic leukemia. You have cells sometimes which are irregular nuclei or hypogranular. You have cells which are hypogranular but with faggot cells. You have cells with these apple core nuclei with abundant granules. Sometimes you have regular nuclei, like in the case we saw, with abundant granules. Sometimes you have regular nuclei with no granules. Okay, this is one of the most difficult APL to diagnose. All right, so this gentleman described this classification system and so on. But it's important to note that sometimes you can get these shadag-like granules. Sometimes you can get cells with absolutely no granules, but these Pelger-like nuclei. And sometimes you can get these blotchy granules. Okay, so the message to take from this is that do not by heart the irregular classification, but recognize that variations in APL morphology occur. It is important to be aware of this because once again, APL is an emergency diagnosis. The thing that to note is that they have a granular morphology and intense MPO stain. Do not confuse. So I see this many times that in patients with sepsis, in patients with intense chemotherapy, you see a lot of promyelocytes, and they'll say, oh, 20% promyelocytes. This is APL. The answer to that is no. In APL, all the cells are abnormal promyelocytes. There is a maturation arrest, which will never occur in a normal or a reactive. Okay, APL can also present with pancytopenia. Just to be there, search the edges of slides when you look at the peripheral blood. Okay, so who's going to talk about the third case? So maybe our twin colleagues can talk about where they went. Sita. No, not Sita. So who's that? Okay, once again, the gentleman, can you please mute yourself? Whoever it is in the background, I don't know what's happening. Okay, 5-year-old girl with leukemia, bone marrow. What do you see?
Hypercellular.
This is a bone marrow. It's extremely, extremely cellular. And what do you see here?
Blast cytoplasmic.
Okay, maybe some maculations, but what do you see here? Nucleus is there, and what do you see in the cytoplasm? So intensely granular cytoplasm and maybe some blast-like cells. Okay, and what do you see here? Do you think this is regular or what do they have?
Convolution.
They seem to have some folding here, no? You can see that these cells have got folding, no?
Yes.
So nuclear folding is going on, abundant granules are present. So intense NPO positivity. And there somebody mentioned flow cytometry. So you have cells with high side scatter, they have variable CD33. Okay, CD15 is dim, 34 HLA-DR is negative, 13 is also dim. So what's the diagnosis?
It's APMS.
APMS. What investigation should be done?
After NPO molecular.
Molecular. So let's see what happens. Okay. Now what is this? PML RARA. Do you think it's positive or negative? Negative. 2 red, 2 green. No, negative. This is PCR. This is our case. Do you think it's positive or negative? This is control. What is it?
Negative.
Negative for PML RARA. Now this is it. RARA break apart. What do you think? Positive or negative?
Positive.
How positive? You are seeing 2 yellow signals. So that means it's not rearranged. Right?
Not
The RARA gene is not rearranged. So kya hai bhai? If RARA gene is not rearranged, how is this APL? So may I ask you two ladies, what is your diagnosis now? Ali, don't laugh. You will be faced with this problem. You have to give a diagnosis. What will you say? Will you change your diagnosis at this point?
Yes.
What will you say?
Not APMS.
Not APM. If it is not APML, what is it? CLL?
No.
ALL? What is it then? You have to say something on morphology. Normal to nahi hai. You agree? No, it's not normal. So what is it? Abnormal है ना? तो अभी इतना सारा blast देखा तो क्या लगता है ये?
Acute.
Tough case, no?
Yeah.
Okay. Why are you changing your diagnosis? I would like to know that.
Concept molecular cytogenetics.
Oh, होगा अपनी जगह. But on morphology, what is your diagnosis? What?
On
morphology, what was your diagnosis?
APMS.
APM. So why do your morphology diagnosis has changed? Are you seeing abnormal chromatocytes? Yes or no?
Yes.
Yes. Is the MPO staining intense? Yes or no?
Yes.
MPO staining is intense.
Yeah.
So why should you change your morphology diagnosis? So here's where some amount of case. So this is an advanced case, all right? We saw this case and they showed it to us and PML RARA was negative, and then I saw the case and I said, no, I think this is still APM. Then I said, kya baat kar rahe? But RARA is negative, this is negative. Somebody is saying, sir, could it be hematogens? So I don't think so. Okay, this cannot be anything else other than APM. I have no differential diagnosis. So I'm not going to go into this. We did a complicated RNA sequencing experiment, and what we found is a TBL1XR1 RAR-B fusion. Okay, so what is going on? What is this RAR-B business? So there is a series of patients that has been described by Chinese literature where these patients were morphologically diagnosed as acute promyelocytic leukemia, but they did not have PML RARA or any known RARA gene rearrangement. Okay, and this is a series of some 7 or 10 patients which has been diagnosed from China. All right, these patients did not have RARA gene rearrangement, but these patients did not, or at least some of them responded to RARA. What they found when they did RNA sequencing in these patients is that these patients, although they did not have RARA gene rearrangement, they had other features such as RAR-B, RAR-G fusions, as well as other fusions like NPF1 and certain other genes. Okay, RAR-B and RAR-G fusions. And this is called as APL-like disease, or acute promyelocytic leukemia-like disease. But the thing to note from this is that if it looks like a duck, if it walks like a duck, and it quacks like a duck, then it must be a duck, isn't it? So don't change your morphological diagnosis because there must be an explanation for what you're trying to see. Okay, so that's this case. Case number 4. So who's the next person that we're going to interview? So Neha has answered. Has Dr. Palak answered? I think she saw the first case, right?
Yes.
So Dr. Palak, did you discuss the case? You did see the first case, no? I can't hear. Dr. Ibrahim, would you like to discuss this case?
Okay, sir.
All right, let's go. So 59-year-old female is particularly leukocytosis and thrombocytopenia. So what do you see?
High TLC count.
So there is definitely leukocytosis. Also, do you see anything else? Anything else you can see? So from this, what I can see is everything is on the WBC front is all gulu gulu. No? So everything is arrested. I don't see gulu gulu as well as convoluted cells. So that means that everything is stuck at one stage of maturation. So definitely abnormal. Definitely nuclear, I would say. Okay. Now what do you see?
So atypical mononuclear cells having large cells having opened up chromatin, high NC ratio, moderate amount of NC ratio, no granules seen in the cytoplasm, and
some more. Okay, we can see some more. Anything else you see here?
Cup-like blast.
Like nuclei.
Nuclear folding.
Imagination.
So
Grooving.
nuclear folding, nuclear grooving is there. There is intense NPO positivity. But you see this? There are also these buttock shaped cells. Okay?
Figure 8.
This is figure 8. So now what's your diagnosis?
Sir, APML.
APML. So out of all of you, how many agree for APM?
Sir, AML NPM1 mutation.
Straight away. तुम तो एकदम distinction holder है. Okay, all right. You're right. But you know, it is not so easy in real life because especially when you don't have seen so many, you know, when you're starting to find your feet in pathology, if you see something with such strong MPO, you will definitely be starting to think of whether this is APM. Okay, and especially when you then start to look at this smear more and more, you'll see this cup-shaped folding. Okay, cup-shaped blast like not figure of 8 nuclei like this. But the important thing to note here is what some of you have seen is that there is this nuclear cupping going. Okay, you see this here? You see this here? Nuclear cupping, almost like an ice cream. No,
Yes, sir.
like an ice cream scoop of cytoplasm. It's very beautiful. All right, so even here you can see this. So if you see the flow cytometry, all of you are like flow out. So this is why I was saying that flow cytometry is not very helpful in the diagnosis of APM. They are 34 negative. These cells actually are negative. They are slightly positive for 33, and there is variable positivity for CD40. Okay, so this is very similar phenotype to APM. Okay, the key to remember here is that is this acute promyelocytic leukemia? That is the only question you will have in your mind. And if you see flow, if you rely just on flow cytometry, you are going to be super confused. Okay, so anybody, the diagnosis is made on morphology, and you have to be confident that this is not acute promyelocytic. Okay, so these are cup-shaped. Okay? These are cup-shaped blasts, and these blasts have MPO positive, cytochemical MPO positivity, and this is often associated with NPM1 mutations. However, it's not specific. It can be seen in FLT3 mutated AML as well. You can also get this figure of 8 shaped nuclei in this case, but it is important to note that these figure of 8 nuclei are not entirely specific for AP. They can be seen in other AML, especially NPM1 mutated AML. However, they will be in a vast minority. Okay, so if you see the majority population, they will look like blast or cup-shaped blast, and few cells will be showing this figure of 8. Based on only one figure of 8 or two figure of 8, please don't make the diagnosis of AP. Okay, so is this the only morphology of NPM1 mutated AML? The answer to that is no. They can have monocytic or monoblastic differentiation as well, as you can see here. They can have multilineage dysplasia, as you can see here, and they can even have sometimes MDS, RAB, or CMML like presentation. But that is very, very specialized postgraduate kind of stuff. Let's not get there. All right. So what should you take home from this message from this case is that they can have monocytic morphology, cup-shaped morphology, or multilineage dysplasia. The cup-shaped blasts are strongly MPO positive. They're negative for 34 in DR, and not to mistake this for acute promyelocytic leukemia. Okay. All right. Next case: 34-year-old female, persistent anemia, thrombocytopenia, and recurrent infections. Okay. So who's the next person? Dr. Ibrahim, I think, discussed this case. Who's the next gentleman? Or lady? Are we all done with all the 6 students? Nobody's left? Ruchi ji, can you comment if I've interviewed everyone? I'm also confused. Okay, so maybe we can ask Sheena and her friend to jump in. No worries, I'm with you. Okay, so 34-year-old female, persistent anemia, thrombocytopenia, and recurrent infections. Now what is this big blob?
It's a particle.
Very good. So this is a bone marrow particle. What is this? What is this?
Trails.
This is a trail. Very good. So when you see bone marrow aspirates, you have to look for these and you have to look for these. Okay, and this is where you do the hematology counts. Now what do you see here?
Megs.
Megs. And would you like to comment on these megs? Are they normal? Are they abnormal? Are they just hunky dory?
Hypolocated.
Hypolocated. All of them are hypolocated.
No, the first.
Okay, so their lobes are, I agree with you. Something is weird about these lobes. No? These lobes are small and they are broken apart. Here also there seems to be some weird clustering going on. This is almost a very small meg. Okay, baby meg. These are almost looking like micro megakaryocytes. Okay, and their nuclei are broken apart here. Okay, and what do you see here?
Maybe not.
Atypical cells. So abnormal. There are blasts. So there are some blast-like fellows in them going around. All right. And what else you see is happening? What is this?
Dyserythropoiesis. By
This is dyserythropoiesis. This is
nuclear budding.
nuclear budding. Please talk about the cell on the red here. Like, can you see my red pointer?
Yes.
तो ये क्या है?
Hypolocated.
So if you see, this is firstly कौन सा उसका सरनेम क्या है? ये कौन सा है? Myeloid cell कि lymphoid cell?
Myeloid.
Okay, so that much तो is this is myeloid cell. तो ये mature myeloid है कि immature myeloid?
Mature.
Mature. Your friend is right. This is mature cell. Okay, अगर mature है तो कौन सा है? Neutrophil है, band form है कि क्या है?
Neutrophil. But hypolocated.
Neutrophil है. अरे hypolocated कैसे? Neutrophil तो है ना? अच्छा 2 लोग है शायद तीसरा भी हो सकता है. But what is not right about this neutrophil?
Granules are absent.
Granules are absent. So this neutrophil lacks granules. Okay, this is hypogranular neutrophil. And what else is happening here? What is happening here? Some of you guys got this right.
Nuclear budding.
So nuclear budding is happening. And what is this? What is this? But what? Verified, yes. But what is the abnormal? Yeah, again, nuclear budding. See, the cytoplasm is just like this one. No, it is completely hemoglobinized. But what this nucleus is doing here? This is called as nucleocytoplasmic asynchrony. By now, this should have been Tata bye-bye, but it's still there. Okay? So there is nucleocytoplasmic asynchrony, there are blasts, there is nuclear budding, there is dysphoesis. And what else is there? There is some. Okay, so let's have some fun. What cell is this? This one. So erythroid. Okay, erythroid cell is there. No? What is this?
Hypogranular.
And what is this? So almost getting to be monolobate. Okay, almost getting to be monolobate neutrophils. Maybe lobes, but it is becoming smaller and smaller. Okay, so there is. What do you think together now? What is happening? All of this, if you put together, what is happening to this case? So let us summarize. Blasts are 40%, and then there is flow cytometry. Okay, you can see that there is presence of blasts. There are blasts which are DR. 33 is moderate, 117 is moderate, 13 is moderate, 38 is good. So there's just that they show a myeloid phenotype. But summarize the case. What all you saw?
Multilineage dysplasia.
Right. So we saw dysplasia of multi lineages and multiple lineages. What's the diagnosis?
AML with Gata to Nikon.
Hi Ram, who is this? तुम्हारे आंखों में genomics machine है. Who is this gentleman? Or lady, sorry, who is it? So not really, all right? Not really. You cannot make those kind of diagnoses on morphology. On morphology, I just see an AML with multi-lineage discourse. Okay? That's all I can say. I cannot say GATA 2 hai and all this. It's just, it's just fiction, science fiction. You can see all of that. You can say APML, you can say NPML, and that's about it.
AML.
Okay? So if you see dysplasia, there are two ways to go about it. One, are there blasts in the bone marrow? Are they more than 20%? Or are the blasts less than 20%? If they are less than 20%, what is the diagnosis? If you get myelodysplasia and the blasts are less than 20%, what's the diagnosis?
MDS.
Obviously, MDS. If the blasts are more than 20%, what should you ask next? Has the patient received any kind of chemotherapy? First question to ask, is this patient known patient of cancer? If the answer to that is yes or no, does the patient have previously documented myelodysplasia or MDS NPM? If yes, straight away AML with myelodysplasia related changes. If no previously documented MDS or NPM, if he has got past chemo or radiation therapy, what does it become? Myeloid neoplasm post cytotoxic chemotherapy. That is its own separate entity. It can be MDS, it can be AML, it can be NPM. But post cytotoxic therapy is its own separate WHO entity. All right. So if none of this is there, and if you have any of these fusions, it becomes, can it be myelodysplasia related changes? No, it becomes this particular. If no, is there dysplasia in 2 or more cell lines? If dysplasia is there, it is still AML. So this is major change from the WHO classification. Today's time and age, if you see AML with dysplasia involving multiple lineages, it is still AML. But if there is presence of a specific cytogenetic abnormality or specific molecular abnormality, only then you can make it AML with myelodysplasia related changes. Okay. So the major change in WHO from 2016 is that if you see multiple dysplasia and all of this is not there, it cannot become AML. Having said that, if you see dysplasia in multiple cell lines, it is almost impossible to get not get an AML because some of these abnormalities will come off. All right. Okay, last case. Now, who's going to volunteer for the last case? Who's not made any discussion so far? Anybody wants to go for it? Any volunteers? No? Should I pick someone, or you would like to pick? Maybe Sita and Neha can both check. How's that sound?
Okay, sir.
All right, let's go for it. So 18-year-old male leukocytosis and large tonsils. What do you see here?
Leukocytosis.
Leukocytosis.
Leukocytosis. Okay. Now what do you see? Sorry, Neha, you say it aloud. It's okay. It's okay to make mistakes. No worries, don't be scared. I made a lot of mistakes when I was in MD. I should not like only hematology. Let me tell you.
Myelocytes and metamyelocytes.
Myelocytes and metamyelocytes. Okay. Who would like to contest myelocyte and metamyelocyte? Anybody? See, these both are making a lot of correct diagnoses. You have to tell them that why they are wrong. No, who wants to fight with them? Do you agree these are myelocytes and metamyelocytes? They're both laughing.
Yes, sir.
Monocytes.
They are metamyelocytes. So we have you three are in one gang. Dr. Ibrahim and others, would you like to contest this? What about the rest of them? Do you think these are myelocytes and metamyelocytes? Okay, so let us contest this. I would contest this, and maybe you can all join me. So can you talk about this cytoplasm? Is it light or is it dark?
It's light.
It's light. Okay. Do you think there are presence of granules here? Or
No, sir.
No, sir.
So maybe there are chotu granules, but largely they are not there. Largely, I would say the granules are not. Okay. What about the nucleus? Some indentation is there. Nucleus is there. But can you talk about the chromatin?
It's less opened up.
It's actually very fine. Okay, if you see this, is very fine chromatin is there. Almost like a rumal. Okay, pathology has a lot of this nonsense imagination, but sort of like a lace like chromatin or like rumal. Fine chromatin, no? Fine lace like chromatin. And what can you say about nuclear margin? Is it
Irregular.
It is irregular nuclear margin. Okay, so now can you put all of this together and try to tell me what lineage it is at least?
Monocyte.
One-time cytoplasm, no granules, fine chromatin.
Monocyte.
So at least monocytoid in lineage. Okay, monocytoid in lineage. If it is monocytoid, do you think this is mature or immature?
Pro-monocyte it can be, sir.
No. So mature or immature? Pro-monocyte. So why do you think pro-monocyte? So the cells are not like this. Okay? They are not very folded, and these are, I would say, more mature monocytes. But these look like what I told you. They look like brain, like a walnut. Would you say this looks like a walnut? Maybe no, with a bit of imagination, like a walnut, but definitely like a brain, indented, right? Like indented, like a kidney, any form. What they say. So a lot of folding is going on in the nucleus. Now look what is happening here. Folding in the nucleus. Okay. Some have prominent nucleoli, and some show presence of granules, but not all.
Granules. Yes.
But not all. And what else is there? What else is there? What are these fellows?
Milo.
What are these fellows?
Milo.
And from
Band form.
Band form.
But band form होगा, myeloid होगा, तो तुम्हारा ऐसा nucleus रहेगा क्या? Neutrophil की जैसा nucleus रहेगा? Does this look like a neutrophil of a nucleus? Not really. No, this cytoplasm is not that of a neutrophil. No, it is very pale. So these are all monocytes. Okay, mature monocytes. Okay. So you have blasts, you have monocytes, you have promonocytes, and there is AML. I would say that this is like a, see this. These are monocytes, maybe a promonocyte, and there are all kinds of monocytic series here. See, this is so beautiful. You are seeing promonocyte, maybe promonocytes here, maybe monoblast here, and a proper blast here. So all kinds of maturation you are seeing. Okay? And what you see here, you see again myeloid maturation. These cells have bright CD64, 33 is there, 36 is there, 117 is negative, DR is positive, 34 is negative, and 11B and 15 are there. But important thing to note is that 36 and 64 are there. Anything you want to comment on 36, 64, and 11C? What do these signify? These are monocytic markers. Okay, they are monocytic markers. If you see two or more monocytic markers, they are suggestive of monocytic change. So how will you summarize this case? You have monoblasts, you have monocytes, you have promonocytes. Okay, this is monocytic lineage cells. Okay, so what is the differential diagnosis of monocytic leukemia? Hypogranular, APM.
APML
Hypogranular. And what can help you distinguish this? MPO. These cells are negative for MPO, positive for NSE, whereas APL and hypogranular APL are strongly positive point of view, as well as NPM1 mutated. Okay. So for monocytic lineage demonstrate, you have to show one or more monocytic associated antigens or NSE positive, okay, which we saw in this case. So there is something called as rule of 20. More than 20% blasts are blast equivalents. More than 20% granulocytes, more than 20% monocytes is acute myelomonocytic leukemia. Whereas in acute monocytic leukemia, more than 20% blast or blast equivalents and 80% are monocytes and promonocytes. Okay, and less than 20% granulocytic cells. So that is how you distinguish M4 from M5. Today you don't call them M4, M5. You call them myelomonocytic leukemia and monocytic leukemia. There are some additional nuances here, such as how to distinguish CMML from AML M4, but that is perhaps discussion for another day. So with that, I'm going to conclude and be happy to answer questions. So Rajiv sir and Gujarat sir, if they have any other questions.
Thank you, Dr. Nikhil. It was a very nice presentation. You have very lucidly explained all the different morphology of AML, and I hope the students might have learned a lot from this. So, any questions from anybody?
So please explain the break apart fish.
So good thing, break apart fish is a probe wherein you want to look. It is typically used when you want to look for a rearrangement of a gene, the partner of which you don't know. So where do such fusions or translocations take place? Can you tell me? So do you know what the term promiscuous means? So promiscuous is a term for somebody who has many boyfriends or girlfriends. It's a common English language, promiscuous. But in terms of genetics, promiscuous is a term for a gene that can have many partners. Do you know of any such gene? MLA gene or KMT2A gene, it has more than 100, 200 partners described. Okay, so in those cases, you use a break apart probe like KMT2A break apart, where you just say that the gene is rearranged. Similarly, for PML, RARA, and others. So if the gene is rearranged, you see a break, and you say that okay, there is a rearrangement happening. All right, so that's it about break apart. Any other question?
Nikhil, Dr. Ajit, yeah.
Yes, sir.
Can you hear?
Yes, sir.
Yeah, really good presentation. You took them starting from the very easy APL to progressively more difficult ones. And I just wanted to find out about this entity called RARP which has been described by Chinese. This was based on NGS, no?
Yes, sir. Full transcriptome sequence.
Yeah. So in this case, is there any specific translocation which you can do in the absence of NGS? Like
so
RARP?
So what we do is we have a targeted sequencing or RNA sequencing approach, which looks at RARB and RARG fusions.
Okay.
I don't think you can of course develop a PCR assay for this, but the partners seem to change all the time. So there is no such publication on specific partners, for this. You can develop such assays, but the partners change. We've seen 4 such cases to example.
So did you publish them?
Not really. I believe the pediatric guys, 2 of those cases are pediatric, are in the process of doing it. So they have written this up and conduct a review somewhere, but they are doing it. So I typically don't do case reports. I'm not interested.
And do they with ATRA or arsenic trioxide? No.
So out of 2 pediatric patients that they were, one responded to ATRA and the second one responded only to 3+7. As of now, there is no consensus. The adult patient also they tried ATRA, didn't punch, they had to treat him with 3+7. So it's still anybody's guess as to how they should be treated. Even the paper from China does not confidently comment on this. They respond to this.
Okay, great.
It's just that these cases are so rare, sir. There is no confidence.
Yeah, very rare. Yeah.
Oh, no opinion on how to treat.
But as you emphasize, the important thing is that in most of the cases, one can diagnose APL on morphology, as you said.
Yes.
And that is very important because the patient is there in the ward in the evening and he's gone next day morning. It's like that. So you have to give a diagnosis very, very fast.
Yes.
Thank you, Nikhil. Are there any questions or any comments from any students? Nikhil, I think excellent talk, and we look forward to have your second talk soon.
Yes.
Any final comments you want to tell Nikhil to students? Anything?
Maybe one question, there is some unverified says should all the rare variants of APL be diagnosed just on peripheral smear on an emergency basis? So I would say yes, with the caveat that peripheral blood diagnosis of APL may not always be easy. These patients can present with absolute cytopenia, and you have to carefully pick these cells up by looking at the periphery. These cells may be distributed just at the periphery. So yes, you can do it, provided you are confident. So if you get patients with cytopenia, you would require bone marrow to be confident.
These are not the upcoming talks. These are the 2 years back talks we are showing. Please remove this slide. Yeah. Upcoming talk is Dr. Mufaddal Muneem. He's going to speak on non-CML chronic myeloproliferative neoplasms like T vera, essential thrombocythemia, myelofibrosis. So Mufaddal is professor at Charing Cross Hospital, Hammersmith Hospital, London, and he'll be speaking on refined biopsies. How do you approach CML and other non-CML myeloproliferative neoplasms? Anything else?
No, sir. There are no more questions. I don't have any comments to make. I would like to point out that please do not ignore morphology. In our lab, we do all kinds of highly, ridiculously advanced tests. Some necessary, some unnecessary. But morphology still remains as the cornerstone for a proper diagnosis. If you don't get that right, you will go on a wrong path altogether. So if you see morphology properly, most cases can be diagnosed reasonably accurately.
Agreed.
Thank you.